So good afternoon and welcome to Navaja's July Lunch and Learn. Thank you for joining us and for your interest in this month's topic. My name is Amanda Karin and I am Navaja's Loudon Director. I'm joined today by my colleagues, including Jill Norcross, our Executive Director, and Hannah Matuda, our Deputy Director, as well as valued members of our Boards of Directors and Leadership Council. For today's program, we wanted to explore the connection between health and housing. It is well documented that housing stability is a key social determinant of health, shaping our physical and emotional well-being, and that access to affordable homes improves the health outcomes of our community. Please join me in welcoming Dr. Tanya Atkins, the CEO of HealthWorks for Northern Virginia, and Dr. Celissa Lambert-Woodard, the President and CEO of Pathway Homes. They will lead today's conversation on the intersection of health and housing. And at this time, I'll turn the microphone over to Dr. Atkins to share a little about herself, the work she does at HealthWorks, and her presentation on the role of community health centers in addressing housing needs.
Good afternoon, and thank you for joining us today. My name is Dr. Tanya Atkins. I am a board-certified OBGYN. I started my career in the Navy and then went into private practice, but something was missing. I knew I wanted to be in community medicine. So over my 27-year career, I have spent probably 20 years of my career working in community health. And I'm happy to share with you today what I've learned about health and housing. I worked at HealthWorks for the first 6 years of my career as an OBGYN before transitioning into the Chief Medical Officer role and then the CEO role for the last 3 years. So we're going to talk a little bit today about the intersection of health and housing in low-income communities. And we're going to talk about how community health centers play a role in addressing those needs. Next slide. So again, role of community health centers in the community. What are our social determinants of health? How is housing a key social determinant of health and inequities in health and housing? Next slide. So I want to talk a little bit about community health centers because most people don't understand what a community health center is, and more formally, a federally qualified health centers. So community health centers, we're nonprofit organizations. We're governed by patients. We have to have 51% of our board have to be consumer members. We are designed to provide quality, comprehensive primary health care to America's medically underserved communities. So we serve all patients regardless of their insurance status or ability to pay. Currently, the 2023 numbers show that about 32.5 million patients are seen by community health centers. We see about 1 in 10 people in the United States, 18% uninsured, 62% are publicly insured, 90% of those have low incomes, and 64% are people of color. There are approximately 1,500 community health centers in the U.S., and the 1,500 health centers provide about 16,000 healthcare sites across the country where people can be seen. So a little bit about our patient population. We know that 1.4 million people seen by health centers are experiencing homelessness. About 9.4 million of our patients are children, and 419,000 are veterans. 3.8 million patients are over the age of 65. So we have a very diverse patient population. Next slide. So why community health centers? Well, we treat the housing insecure. So who better to collaborate with and advocate with for better housing? Because we have integrated medical, behavioral health, and social care, we can identify those patients. We can make sure that they're screened for the social determinants, and then we can assist with helping them with health-related issues associated with their housing. Next slide. So I'm going to take a look behind the HealthWorks curtain. This is data that is presented every year by every community health center in the country. It's called UDS data, Uniform Data Service data. And when you look at HealthWorks, across our 5 sites, last year we saw 72,992 patients for visits. That's a lot of visits. And the highlighted yellow, you can see our Loudoun County sites, and then in white are our Fairfax County sites. Again, when you look, you see that most of our visits are for primary care, and we have a pretty good mix of both pediatric and adult patients. if you looked even further, you would see what's not on the slide is that we see more women than men. And I didn't break the slide down by age, but we see a lot of people over the age of 50. And you can see our services here. In addition to providing primary care, we have laboratory services and we have pharmacy services. Next slide. When you look at our patient demographics, what you'll see is that they mirror the patient demographics across most of your community health centers, but I'll show you where we might be different in some ways. First of all, 86% of our patients fall 200% or below the federal poverty level. That's a lot of patients. And when you look at the unique patients by language, you see that 71% of our patients identify Spanish as their primary language. But we serve about 77% of patients in a language other than English. Next slide. When you look at our payer mix, you see that over half of our patients, 54.37%, are uninsured. Of those uninsured patients, 28% have Medicaid. Very few of them have Medicare. When you look at community health centers across the spectrum, though, when you look at their uninsured rates, those rates are usually around 20%. So in our geographic region, we're serving a population that has much more uninsured or much more likely to be uninsured. When you look at the Medicaid rates and you look at an average FQHC, 60 to 80% of their patients are going to have Medicaid, whereas for HealthWorks, we only have about 29% Medicaid. And that makes a big difference in how our organization needs to be funded, because we have to make sure that we can pay for those patients who are uninsured. Next slide. So when we look at the social determinants of health, I think everyone has seen the graphics for social determinants of health. But I like this one because you can see that 40% of those social determinants are socioeconomic factors. 10% is their physical environment. 30% are behavioral issues, such as smoking, alcohol use, sexual activity, diet, and exercise. And then 20% is derived from not just quality of care, but access to health care. Next slide. So when we think of housing, I like to break it into 4 pieces. You look at the house, and that's going to be your structural, your structure, the 4 walls. But when you look at the home, we're talking about the psychological aspects, the social aspects of the house. Who lives in the house? Is it overcrowded? Do we have people who are chronically ill? And then you look at the community, and those are characteristics that are important, like, is there a grocery store in the community? Where is transit? Where's our public transit related to the location of the house? And then we look at the neighborhood. Are there parks in the neighborhood? Are the sidewalks and streets, are they safe? So you have to look at the house as not just the 4 walls, but all the things that encompass a home. Next slide. So what are the consequences of having housing insecurity? Well, you're going to have chronic stress and anxiety, depression. We know that there are high rates of asthma, respiratory illnesses, poor chronic disease management, and ER overutilization. Next slide. When I delve a little bit deeper into what some of those things could be, one of the things that comes top of mind is lead-based paint. If you live in a home that has lead-based paint, your children may suffer with lead poisoning. 2021 study from the American Healthy Homes showed that 35.6 million homes, that's 29.4% of all housing units in the US, still have lead-based paint. 28% of those units have children under 6 in residence. So we have to continue to move forward to fix this. What I found in that study is that a lot of this is not inner city. A lot of these are rural homes, and they're single family homes where there's no one really advocating for these folks to get the homes up to standard. When we look at substandard housing conditions, things like mold, mites, allergens, they lead to chronic respiratory conditions like asthma. And 40% of asthma amongst children is believed to be attributable to residential exposure. Things like cockroaches, carcasses. Those are allergens that you think, well, how do they help affect health? But those carcasses have allergens in them that will trigger asthma for children. Think about carcinogenic air pollutants like radon, or things that are even more common like tobacco smoke, pollutants from heating, cooking with gas, or volatile organic compounds and asbestos that we know are linked to respiratory illnesses and some types of cancer. And second to last, home injuries. About 4 million emergency department visits and 70,000 hospital admissions every year are due to factors like structural factors, steep stairways, our elderly coming down very steep stairways and they have a fall. Safety devices, there are no safety mechanisms on windows. Smoke detectors, no smoke detectors in the home. And then substandard heating systems that may cause people to use alternative heating mechanisms like heaters, floor space heaters. And then residential crowding. We know that physical illness, including some infectious diseases, they like TB, COVID-19, and flu, can have psychological stress on both adults and children. I think back to COVID-19 when I was the chief medical officer. We asked people to quarantine because, when someone in the family got COVID. But if a family of four is living in one room, where do you quarantine? And that's when it really became evident to us that overcrowding is a problem. It's a problem psychologically, but it's also a problem physically. We know that children in crowded housing have poor cognitive and psychomotor development. They become more anxious, socially withdrawn, stressed. Next slide, please. So I want to take a look at something that I find very disturbing, and it's location. Where you live matters. And if you look at Loudoun County data, this comes from the Northern Virginia Health Foundation, and there's a link to the two-pager where this came from on the slide. But if you look at census tracts, which is what we tend to track in the health system, because when you look at a city, it doesn't give you a really good look into what's happening near your health centers. So we use census tract data. And I have to look at all the census tracts around where we have our health centers and look at that data to decide what services we're going to provide. Also, if I wanted to open a new clinic somewhere, I would look at the census tract data around that site to make sure that we are reaching the people who need to be reached. So this is a lovely study of two different census tracts. Census tract 6119 is in the Ashburn area, and census tract 6116.02 is in Sterling Park. And when you look at this, you can see some very stark discrepancies between these two areas, both in Loudoun County. So when you look at the Loudoun County data, you say, well, Loudoun County is the richest county in the country, but you have to dig deeper to find out where those inequities are. So if you compare, let's look at ethnicity data. 51% of the patients or the people who live in tract 6116 or Sterling Park are considered Hispanic, compared to 6119, where the Hispanic population is only 3%. When you look at income, that income is almost at least 2.5 times lower in census tract 6116. You look at poverty, child poverty, public assistance, and single parent households, you can see a very stark difference. If you live in a single parent home, you know that your income is going to be a little bit lower, right? And that's the data bears that out in looking at the median household income. And then look at renter occupied housing. In Sterling Park, 45% of people live in an apartment or somewhere where they're renting. Whereas in Ashburn, that's only about 4%. And when you look at housing problems, 73% of people who are renting in Sterling Park have some housing problems. And I wasn't able to dig deeper into what those housing problems are, but you could imagine that they're suffering with substandard housing, possibly eviction. And then look at overcrowding, 7%. Doesn't seem like a high percentage, but if you're a family of four living in a one bedroom or one room house or apartment, there is overcrowding, and that is a problem. And then look at the uninsured rate. 32% in our Sterling Park area compared with 4%. in the Ashburn area. And then private insurance is uniquely different as well. And I say that because if you just drive 5 miles from where 6119 is, you might get to an area where, like Sterling Park, where you have such a disparity in health, income, and housing. Next slide. The same can be said is true in Fairfax County. We have a center we call it the Sully Center. It's in the Sully district, but compare that to an area in Chantilly, and you'll see again, the renter housing occupied is higher. The housing problems are going to be higher. Uninsured and insured rate is going to be different, and your ethnic and racial background is going to be different, as well as your median household income. I love this study. If you've not had a chance to look at it, it was sponsored by the Northern Virginia Health Foundation. And again, the links to this is in the slide. Next slide. So where can we help? What can we do? There have been some innovations and interventions, such as medical legal partnerships, that's embedding a legal person inside of a health center to help with housing problems. They can help with evictions. They can help with things that need to be repaired. You have that legal resource directly involved in the health center to help. Housing navigation and social work. Having a social worker embedded in your health center to help patients with housing navigation is extremely helpful. And then partnerships with housing authorities. I know that there are several several builders or organizations that are looking to build low-income housing, and I've partnered with them to say, we will put a health center, or we will partner with you to provide healthcare in these low-income housing developments. And then for community health centers, how can we help? One of the things that I'm looking at is getting a mobile outreach so that we can go to these housing areas, since we can't embed within them, and provide healthcare to them at their location. Next slide. What policy changes? Well, funding for housing first models, where it doesn't matter. The most important thing is that person gets housing. Everything else is secondary. Continue to give Medicaid waivers for housing for those who have disabilities. And then local and state partnerships, partnering with home builders to build affordable housing. And I think what's most important is that we want to make sure that community health centers are at the table advocating with you for good housing. I think it's a piece of the pie that's been missing, but I see it starting to be recognized that we can advocate with you and for you in making sure that our clients get better housing. Next slide. So this is my call to action. I'm going to make sure that I'm screening for housing in all of our clinical workflows. Every time we see a patient, are you housed? Are you unhoused? What are the housing issues that you have? I'm going to reach across the aisle to my neighbors that do job sourcing, food, housing, so that we are all on the same page, working together to ensure that our clients get what they need. And then I'm down on the hill, or I guess up on the hill in DC every January and December with our advocacy agencies, the Virginia Community Healthcare Association, and our national community health communities, making sure that we are advocating for policy change, because it starts there. And the last thing is, we have to amplify our patient voices. Our patients have stories to tell, and that is what moves the needle. Until our patients tell their stories, it's often just words on a page. So please, when you're looking for ways to move that needle, contact me. I have lots of patients who would love to tell their story and be beside you when you're advocating for change in housing. Next slide. So closing thoughts. Health and housing are interconnected. We all know that. Community health centers are on the front lines. These are our people. These are the people we take care of. So we know their plight. Better housing equals better health, and you can't get well if you don't have a place to live. And that's kind of my mantra for everything. If you're not well, you don't need food. If you're not well, you don't need clothing. If you're not well, you don't need housing. So the most important thing is to be well. So thank you so much.
Thank you so much, Dr. Atkins, for your presentation. If you haven't already done so, please type your questions for Dr. Atkins into the chat, and we will address as many as we can during the Q&A section of our program. And now I'd like to turn the microphone over to Dr. Lambert Woodard to share a little bit about herself, the work she does at Pathway Homes, and her presentation on how access to safe and supportive housing improves health outcomes for our most vulnerable neighbors.
Thank you, Amanda, and thank you, Dr. Atkins. I certainly appreciate your presentation. I'm Dr. Celissa Lambert Woodard, President and CEO of Pathway Homes of Northern Virginia, Washington, D.C., and Central Florida. I'm also a licensed clinical social worker, a licensed treatment provider, substance abuse professional, master's addiction counselor. And I mention that because in my spare time, I'm also a psychotherapist practicing actively in the DMV, really focusing in with our practice, which is a Christian and veteran-owned practice, and serving individuals in our communities with trauma, veterans, individuals who are reentering into the communities, and individuals with serious mental illness. So this is a topic that's close to my heart and something that I have a great deal of passion and look forward to touching base and sharing some of my experiences and information with you this afternoon. So safe and supportive housing, a key to better health for vulnerable communities. The introduction, our next slide, is really a focus today on our objective, which is really going to be in demonstrating how safe, stable, and supportive housing really improves health outcomes while really promoting equity across diverse populations. And the populations we're focusing in on are these key vulnerable populations, such as individuals experiencing homelessness, low-income families, individuals with disabilities, seniors, LGBTQ+, youth, children, and those with mental illness. All these individuals and populations face unique challenges that really directly impact their health and well-being. And so understanding these conditions is really essential for creating effective interventions moving forward. Next slide. As Dr. Atkins had mentioned and took a deeper dive in, housing is one of the most significant social determinants of health. Housing is really more than just a roof over your head. It's fundamental. It's a fundamental social determinant of health. And according to the CDC, stable housing is foundational, right, to physical, mental, and social well-being. So where and how people live really influences their access to nutritious food, healthcare, education, safety, really their overall stability. And without safe housing, these key essential factors for health really become precarious. So they lead to poor health outcomes. Next slide. In reference to Dr. Atkins' presentation as well, she talked a lot about location, and I'm going to talk with a slightly different lens and kind of focus on place. And so this acronym, I think, is quite poignant in that it's rest in peace, right? Race, income, and place. These are really the hidden forces behind health inequities. And so really to understand why vulnerable communities experience worse health outcomes, I think we have to look beyond the individual behaviors to those structural conditions. And it's kind of summarized with this acronym. Race, which is really, income and place. The historical racism, such as redlining, has limited safe housing, just as an example, and access for people of color. The lack of income further restricts housing choices for all vulnerable populations, really pushing low-income families, income restricted and disabled into unsafe or unstable environments. And we know that place, right, your zip code, right, is often more predictive in health than your genetics. Place does matter. Location and place matters. Living in disinvested neighborhoods that was mentioned before with poor air quality or scarce healthcare really does worsen health conditions. And income and place act today as proxies for inequality that results in incomes not keeping pace with housing costs and the lack of fair wage and the lack of affordable housing really impacting health conditions and outcomes. So stable quality housing allows for better disease management, right? Individuals with chronic conditions like diabetes, hypertension, HIV/AIDS, are more likely to manage their health effectively when they have stable living environments. Stable housing allows for reduced exposure to health hazards that was mentioned earlier. It protects individuals from extreme weather, from violence, from unsanitary conditions, and environmental toxins, which oftentimes exacerbate these conditions. And in fact, at Pathway Homes, one of the things that we're getting ready to launch, which we're very excited about, is our new social contract with the community. It's called the Mobile Outreach Unit, and it's going to be a van that's retrofitted with 4 showers and handicap accessibility going out into the communities in DC and Virginia and Central Florida to be able to reach individuals where they are, connect with them, and ultimately get them signed up for housing while restoring their dignity through a shower and engagement. And going back to stable housing again, stable housing also allows for decreased emergency room visits and hospitalizations. Many studies have shown that supportive housing really significantly reduces costly emergency care by preventing health crises and death. And we'll talk a little bit more about that as we go on. At the end of the day, the safe and quality and supportive housing, it interrupts the RIP cycle, right? By providing a safe place regardless of RIP, by offering healthcare and case management, by creating a base for rebuilding economic security, for fostering dignity. And I would always say that if RIP doesn't determine risk, right, housing is the intervention that really can revive and rewrite this story. Next slide. Let's talk a little bit about mental illness and homelessness. It's a really complex intersection, right? So many of you know that mental health affects about 1 in 5 individuals annually in the US, and serious mental illness conditions like schizophrenia, bipolar disorder, schizoaffective impacts about 1 in 20 individuals. So there's someone here today, certainly within this gallery, that suffers from a mental health condition or serious mental health condition. But importantly, it's to note that about 25% of the population experiencing homelessness live with SMI, compared to just about 6% of the general population. So these conditions impair daily functioning and are really exacerbated by the instability and trauma of homelessness. So permanent supportive housing provides a lot of mental health benefits, right? So reduced stress and anxiety. Housing stability helps to alleviate that constant stress and trauma associated with being unhoused or housing insecurity. When supportive housing includes mental health services and case management, peer support, which is critical, individuals are better able to engage in therapy, maintain their medications, and avoid psychiatric crises. And PSH is also a foundation I mentioned for individuals with substance use disorders. Of course, substance use disorders is a mental health condition, right? So tailored services, tailored substance use interventions, and particularly peer-led supports really promote recovery and decrease substance use. And housing stability increases treatment retention as well. A safe place to live really enables individuals to participate more fully in less costly outpatient types of treatment or recovery programs and adhere to treatment plans. And it also significantly reduces stressors that trigger relapse. Next slide. So housing access improves mental and physical health. I want to mention to individuals that, older adults in particular and youth happen to be the fastest growing population among those unhoused. It's estimated that by the year 2030, homelessness among older adults is expected to triple, actually. So the complexion of the unhoused really looks different among those older adults. If you're over 50 years old, typically we're seeing chronic health conditions of those who are unhoused, loss of loved ones, they're widowed, frayed or broken financial or support systems. That's if you're over 50. If you're under 50, we tend to see more individuals with SMI, substance use, individuals who are justice involved or underemployed. So we know that from the National Alliance to End Homelessness that if your first experience of homelessness is after the age of 55, your life expectancy is not to exceed 64 years of age. So, all right, prevention has to be the key. We need those natural and community supports. We need those shallow subsidies that I'm always advocating for, sometimes just $300 makes all the difference between someone maintaining their housing or being unhoused. We need the activation of all those resources for transportation, nutrition. All of that's really, really important. But for the older adults that we're serving, they're exhausted. They've had to transition to survival mode of living. And they're living in their cars and on the streets. And so housing becomes the most significant social determinant of health for them. And as you look at this chart, you can see that older adults benefit from reduced acute care usage and improved psychological well-being with housing access. And this is even more critical given multiple comorbidities. For the youth population, especially those aging out or foster care or experiencing trauma, show enhanced stability and reduced mental health risk when provided housing. But mental health symptoms often are still there and require a lot of therapeutic support because of the emerging development of the brain for our youth. And among those individuals with serious mental illness, housing first, right, paired with surgical community treatment teams, intensive case management. These are all programs that Pathway Homes provide services through our ACT programs and psychiatric assisted living facilities and things of that nature. When you're pairing up these services, we're seeing a significant reduction in symptoms and reduced crisis care and better alignment in the community and outpatient services. Next slide. So the root drivers of homelessness, I think it's critical to note that homelessness is not caused by mental illness or substance use, but it's really by the systemic drivers. And so it's primarily the lack of affordable housing, structural barriers like exclusionary zoning, for instance, insufficient political will, inadequate upstream services like fair wages, healthcare, case management. Permanent supportive housing is a proven solution. It's an evidence-based best practice, over 40 years worth of research poured into validating the fidelity of this model and being able to break this cycle and address those root causes. Next slide. So why safe and supported housing is key to health outcomes? Well, there are some key bullets here. Stability reduces stress and improves mental health. You can kind of see the bullets there. Improve access to health care. It supports substance use recovery and mental illness management, reduces risk of infectious disease, and it promotes child development and educational outcomes. But rather than just read the slide to you, I want to kind of pull together some kind of anecdotally some scenarios that really kind of give a more poignant vision and allow you to kind of touch and understand why these are so key, why housing is so key to recovery and health. And for many individuals and families that I've had the privilege and pleasure of serving, good health is not starting with a doctor's visit. It doesn't start there. It really is. It starts with a place to call home. And so the link between housing and health is really clear. As I said, well documented. We know that that's safe and stable and supportive housing provides the conditions that's necessary for individuals to thrive. And we know when there's unsafe housing, there's a rippling effect throughout a person's life. But I want to kind of share kind of a vignette where being unhoused can really trigger a mental health crisis. So take, for example, someone who's experiencing chronic homelessness, and without a permanent home every day, those tasks like sleeping or sleeping safely, or storing your medications, or attending therapy become a significant struggle. So we know research shows that chronic housing instability actually elevates stress levels, right? You see the stable housing reduces cortisol levels, the reverse there is, right? It elevates stress levels when there's housing instability. And so that contributes to anxiety and depression, and in some cases, PTSD. So in contrast, when the individual moves into a supportive housing situation, I see this on a daily basis, perhaps maybe through one of our Housing First programs, they gain not only a place to live, but they gain access to mental health and case management. And over time, their mental health does stabilize. they do recover. And so they then begin to pursue those goals that they previously thought were out of reach for them. When you think about the physical health and disease management, consider a person managing a chronic condition such as diabetes or HIV, and without stable housing, again, adhering, to medical treatment becomes incredibly difficult. So there's no secure place to refrigerate their insulin, no regular schedule to take their meds, there's limited access to healthy food. And so housing instability often means frequent hospitalizations, ER visits, and preventable complications. There's so many different examples that can go on for substance abuse, for instance. Housing may not be enough. It's oftentimes needed to be paired with wraparound supports. Programs that provide these permanent supportive housing services integrate those life skill trainings, treatment services, mental health, the spread of infectious diseases. Again, the comment was made in regards to the impact that we all observed during COVID-19. Housing has always been a frontline defense against the spread of infectious diseases. We know also that cities that rapidly moved people from congregate shelters into individual hotel rooms during COVID-19, they saw fewer outbreaks among the homeless population and a decline in related hospitalizations and deaths. And then lastly, just to focus on the children's health development, we know how housing impacts children uniquely and profoundly. A child growing up in an unstable housing situation, or someone who's frequently moving or living in overcrowded conditions or environments with mold, pests, lead, is oftentimes more likely to suffer from asthma or developmental delays or behavioral issues. And these children also miss school, and then they fall behind academically as well. Next slide. So building a healthy foundation, what makes permanent supportive housing effective and how is it measured? I think it's a simple formula. It's capital investments plus subsidies and support services is the magic formula to use. These programs are grounded in evidence-based work. Everyone is ready for housing is a belief. Housing is a right, not a privilege. Recovery is possible. And we really are working and leaning into this work with a trauma-informed lens, using motivational interviewing and being really non-judgmental and empowering. And the measurements are quite consistent nationally and internationally. The measurements that are used in terms of being able to determine if we're going down the right track is looking at the housing retention rates, looking at the health metrics, the emergency room visits, hospital stays, medication adherence, resident surveys, asking individuals who are served, are they satisfied? Doing those environmental assessments to assess the quality, not just that there's housing, but there's quality housing. Looking at the costs analysis and determining the return on investment. And utilizing best practice scales like the fidelity scale from SAMHSA. And there's another scale that I didn't place on here, which is the General Organizational Index, which is oftentimes used with the fidelity scale to measure the fidelity of the program at the organizational level as well. Next slide. So taking a look at Pathway Homes for a moment, the organization that has been around for 45 years in your backyard has done a tremendous amount of work in being able to really address these issues and utilizing these measurements with over 580 units. Particularly our nonprofit focuses on individuals with serious mental illnesses, substance use disorders, and co-occurring disabilities. So we provide some services to children, youth, and families in DC and Central Florida primarily, but in the Northern Virginia area, we are very much so specialized. And we're finding that our services year after year after year, individuals are remaining in housing, over 90%, 93% in this past year. 95% avoid psychiatric hospitalization, 96% avoid jail, 92% remain in the community, and that's with all individuals that we serve having had past psychiatric hospitalizations. 90% are employed, which is very high for the population that we're serving, near the average. And the cost of services for Pathway Homes, when you're talking about the return on investment, we provide services at about $35 a day compared to a shelter, which is $37 a day, a night in a jail, which is about $355 a night, an emergency room stay, which is about $1,941 a day compared to a psychiatric stay or night in a psychiatric hospital, which is $2,500 per day. So it's really clear to see how permanent supportive housing yields a solid return of investment for our community. Next slide. So it's can't do this work without elevating housing justice, right? So it's really that idea that everybody deserves a safe, stable, and affordable home to be able to live in. And the ingredients are really clear. I mean, there's equity. It's really addressing those systemic barriers, eviction and disparities and gentrification, looking and understanding about affordability, ensuring people aren't forced to spend more than what they're making just to stay and remain housed. The accessibility component, making sure housing is available to all, including all people with disabilities, formerly incarcerated individuals, et cetera. Stability, protecting individuals from eviction and unsafe living conditions, and community power, which really means elevating the voice of the individual that's served in the room. And we do this and achieve this housing justice by looking at stronger tenant protections, rent control, just cause eviction policies, building and preserving affordable housing, through LIHTC, public investment, land trusts. There's so many different ways of being able to think about that. Decriminalizing homelessness, advocating for those low barrier, cost-efficient housing for people who are sleeping outside and panhandling, offering housing-focused models, creating safe transitional alternatives. We need to look at zoning reform, reforming our exclusionary zoning policies, reforming property tax systems, and again, amplifying the voices from the ground. Next slide. Economic and systemic return on investment goes deeper than just the example that I showed you from Pathway Homes. Investing in housing yields really substantial savings by reducing those costs for hospitals and emergency rooms and all those key outcomes that I talked about. But stable housing really has made a significant impact in Virginia. Virginia's permanent supportive housing programs reduced state hospital use by 76%, saving $30.4 million through the years indicated there, generating $1,375 a year in cross-system savings. The references to this at the end of the slideshow. Chronically homeless individuals in Virginia could incur up to $100,000 a year in public costs, whereas if they're housed, it could drop to $8,000 to $12,000. There's significant savings in there. So the real return on investment is that every dollar invested in supportive housing in Virginia really delivers multiple dollars in savings and gains across healthcare, criminal justice, public services, economic growth. And so supportive housing is not just a social good, it's really an economic strategy as well. Next slide. So considerations for improving access, equity, and health. We do need to take into consideration, despite all its benefits, access to permanent supportive housing is really hindered, sometimes by persistent stigma against people with serious mental illnesses and substance use disorders. Again, exclusionary zoning, housing practices, long wait lists, complex eligibility processes, chronic underfunding of affordable housing and wraparound support services. But additionally, policies can continue to uphold patterns that limit access. We, of course, are anticipating HUD's planning and redesign of the COC, which is going to likely shift funding priorities and new practices. We certainly are aware of that. And then, of course, we have the more recent executive order that's really designed to overhaul federal homelessness by and public disorder policy by prioritizing areas such as civil commitments and institutionalization. Some of these approaches we haven't experienced since 1960s and 70s, approaching this more from a law enforcement or required treatment perspective. And so the intent is that a lot of these public safety initiatives are in response to what's perceived as increases in our crime or homelessness and drug use in American cities. And so these are all areas that we will need to work with and consider as we're moving forth to be able to make sure that we continue to elevate right? The most important person, which are our constituents, our neighbors, and our friends in the community, and support them. In a nation as great as ours, there should not be anyone who experiences homelessness. So thank you very much. The next slide gives you a few of the policy and practice recommendations to scale up housing, wraparound services, zoning, strengthening tenant protections, and prioritizing equity. And then the bottom line here is really that safe, supportive housing is healthcare. It heals trauma, stabilizes chronic illness, and advances health equity. And investing in housing is really investing in community resilience, public health, and justice. Next slide. Thank you.
Thank you so much, Dr. Lambert-Woodard, for your presentation. At this time, I'd like to address some questions from the audience. To respect everyone's time, we'll plan to wrap up the conversation right at 1 o'clock, but we'll get to as many questions as we can. The chat seems like it was a bit quiet, but we did get very many very good questions prior to the program. So I think I'll kick off the discussion with a few questions that were sent to us earlier. And if it's okay, I'll start with this one. So this can be to either of you. What are the best ways for housing organizations to collaborate with health-focused organizations? What's working well, and where is deeper partnership still needed?
I think from a healthcare lens, we are always looking to partner with our housing, our builders and our housing programs from the very beginning to get healthcare to get healthcare into the housing units before they're built. I was working with a housing organization who had already built their units, and it's really hard to retrofit then to go in and put a health center in after that the property has been built. So I would say collaborating on the front end to make sure that we're intentional about having space for healthcare built into the housing units.
Yeah, I think Pathways is actually in the process. We've just tried to retrofit a new property in Fairfax City, and so we've had a lot of opportunities to work with partners in the community. And I think the earlier slide that I mentioned in terms of collaborating is really ensuring that we have the right people at the table so that we can develop those the capital and the subsidies and services. It's critical that early in the process there's an intentionality about recognizing again what that ROI is, and the earlier that you're able to plan and create that foundation for support, the more that you'll be able to not only be more inclusive of individuals within existing affordable housing developments, but also scale that to a different level. It's also critically important to always be able to have partnerships with local health agencies, with the community services boards, behavioral health organizations. The work that we do requires a village to be able to provide the services adequately, and without being able to recognize that as we're developing these programs does have a significant impact on the community when individuals are brought into housing or housing is developed without that intentionality.
Thank you. And there's a question in our chat that addresses just the rising costs of housing and how housing is just out of reach for too many folks and costs are increasing. And this may be a question, Jill and Hannah, for us as much as for our presenters, but the question are we seeing other communities of our size and demographics achieve success in addressing housing supply and affordability? If so, what are they doing that we might commend for consideration by our local government partners? Where are communities having success and what can we lift up and replicate here in Northern Virginia?
Well, affordable housing is an issue nationwide, the lack thereof. I will say that in working in Florida near Bidflo, there's some creative strategies that's taking place in terms of the development of tiny home communities that have really scaled nicely. It does require a great deal of public-private partnership to be able to ensure that those rents are low. No more than 30% of what individuals are earning, and oftentimes we know individuals are only earning perhaps what they're entitled to through their benefits. Many of the individuals we serve are only making about $780 a month, and that's in the Northern Virginia area. So yeah, a really successful way of being able to see affordable housing scale positively is that private partnership involving the ecumenical community, looking at being able to have having land donated or land leases that create the foundation, and then building upon that with tiny homes and creative designs that integrate green features that allow for the cost of operational costs long term to be minimized.
I'll just jump in and add from Navaja's perspective. Actually, maybe it's a plug for our event that's coming up on September 30th, but we're actually going to be focusing on what's working with housing policy, both at a national level. We'll have Tina Stacy from Urban Institute be discussing exactly what was raised in the chat, like what are other communities doing that we know are working that we could adopt here in Northern Virginia. And then we will also have a panel about what's working here locally and regionally, some of what Dr. Lambert Woodard raised with using public land for housing, faith-based partnerships, and other models of housing finance that we're seeing being able to make progress. But yeah, the housing supply issue, we really have not bounced back from the crash of 2008 and have not continued to add enough supply of housing to here regionally and across the country, and that's really put us in a terrible bind with housing affordability as we continue to also build committed affordable units as well, especially for those with most vulnerable populations that we're talking about today. So thank you for that question.
Thanks, Joe. And there's a question that said, and this is really for Dr. Atkins, how are federal funding cutbacks affecting the federally qualified community health centers?
So we really won't start seeing major changes until 2026. So right now we're kind of at a status quo. But community health centers were founded to be the safety net for all. And what we're seeing is that stipulations are being put in place so that we only serve certain people. As they begin to have Medicaid cuts, those patients are going to need to go somewhere for their health care because they're going to be uninsured. And so what we as community health centers are gearing for is an onslaught of more uninsured patients coming into our health centers. And we're going to have to figure out how we fund that. We won't see those changes again until 2026. The other thing is we were funded originally to take care of everyone, and stipulations being put on who we take care of may eliminate a lot of our patients. And where are they going to go for their health care? If they can't go to a community health center, they're going to end up in the emergency rooms. Our funding is based on the number of patients that we see. And if you reduce our community of patients by restricting care to the most vulnerable who may not meet requirements for funding, then you're going to also decrease our funding. So more to come. I mean, I think that's the biggest question I get asked every day. How is this going to impact you? We have a consultant working on some modeling for us to see how it's going to impact us in the long run. But as of today, it's kind of business as usual as they figure out how to make all these cuts. And most of them will take effect in 2026.
Thank you, Dr. Atkins. And maybe we have time for one more question. This is a question for both our presenters. What role do support systems like family, caseworkers, or peer networks play in helping people stay healthy, housed, and employed?
We couldn't do our work without our community health workers who really go into the community, and they're the boots on the ground. They're telling us what the needs of the community are. Our caseworkers are working really hard to address those social determinants of health for the patients that come into our health centers. So they're looking for the food and helping them with housing and work. And so they're a very important role in keeping folks healthy.
Just to complement what Dr. Atkins is mentioning, I want to focus, I guess, more on family, both traditional and non-traditional supports that make all the difference. Oftentimes, those support systems come not just in members who are blood related, but they come in the form of service animals as well. And so I just want to put a big plug for the value and importance of being able to have the connections. There's sometimes the service animals can give you, when you're working with an individual, incredible information that's relevant, as well as, of course, the family members that support individuals. And for those who are caretakers as well of our older individuals that we're serving, what a critical support so many individuals who are kind of sandwiched in the generation of both caring for their children and caring for their parents, because without those individuals, an entire safety net would be eliminated. They're providing the transportation, they're assisting with the medications, they're helping to connect with the case managers when they're coming in. So it does absolutely take a village in terms of being able to support those we serve. And I just think every key person who's identified by the person served is someone who needs to be integrated into the treatment plan and service delivery program.
Thank you so
Amanda,
much.
one of the
Yeah.
things we didn't bring up today, it's
Mhm.
a totally different conversation, but workforce housing, right?
Mhm.
So we need workforce housing as well to support our unhoused, because if we don't have people to come to the health centers to provide these services because they work too far away, because they can't afford to live here, then that's another problem that needs to be addressed.
That's exactly right, and such a good point. Thank you for raising that. So in the interest of time, I think we'll go ahead and wrap up. And I just wanted to say thank you so much for everyone for joining us today. And many thanks to Dr. Atkins and to Dr. Lambert-Woodard for their time and their leadership and the amazing work they do in our communities. Just a reminder to everyone to please be sure to visit Navajo's website to register for our August Lunch and Learn, which will include a virtual bus tour of some innovative local affordable housing projects. So thank you, everyone. Enjoy your day and hope to see you all soon.